that you put in for this meeting all through the year. In fact, my wife was yesterday only discussing with me that by the time this conference is over, Dr. Vitull is going to start working for the next year's conference. And that is the level of commitment he has to this, to education. And I must say he has brought very many great physicians to Punjab from all across the country over these last 11 years. And we cannot but be more indebted to him for all this effort. I am going to talk in the next about 13-14 minutes to you about Indian hypertension guidelines. We just heard a lovely lecture on patient safety, and beneficence and maleficence are two essential principles of medicine besides informed consenting and justice. So that was beautifully highlighted. Coming back to the topic for today, you can well make out that the prevalence of hypertension in our population is about 28%. So it's the commonest public health problem that we have. And the story in India is little different from the Western countries. If you look at the right side of this slide, almost 90% of our people do not have blood pressure controlled. So obviously the guidelines that we will have will be somewhat different, because our issues and problems with hypertension are not the knowledge between you and me regarding how best to treat hypertension, but how to implement actually this knowledge into practices. Because we all know it's not only in the urban to the right side and the rural actually, the urbanites are not faring any better than the ruralites, because still 20% people are controlled in the urban areas and 10% people have. Hypertension itself is diagnosed in only 60%. So 40% individuals don't even know that they have hypertension in our country. And that is essentially one of the major issues that we all have to deal as physicians in our country. We know hypertension is a little bit peculiar amongst us, and some of these things we highlighted in the Indian Journal of Medical Research. It occurs relatively earlier amongst us as compared to other communities. There was a bigger rural-urban divide, but as the ruralites are now acquiring more of urban lifestyle, the prevalence of hypertension, diabetes, coronary artery disease was almost half and half between the ruralites and urbanites. But we are seeing a convergence now because of this changing lifestyle, and even the urban people have a relatively higher prevalence of hypertension, and so also diabetes, stroke, coronary artery disease. We harbor multiple risk factors together. What we as South Asians, we know the thrifty gene hypothesis leads us to a syndrome X, which is characterized by a central obesity, insulin resistance, high TG levels, low HDL levels. So our lipid profiles are different. Our prevalence of diabetes is much higher than in other communities, and also hypertension, which is a part of this metabolic syndrome X. So we have clustering, they are close cousins, and people who are hypertensives, they have almost double the prevalence. You all know, we just shared that the prevalence of hypertension in our general population beyond 30 years is about 28%. The prevalence of diabetes in India is about 13 to 14%. So diabetes is the second commonest non-communicable disease. So out of every 100 individual, you can make out almost 40 would be having one of these two. We know in the urban and rural areas, Dr. Pupinder knows, we have done some work in DMC in this area. We live in that part of the equator where summers and winters are very different, and all of us as physicians have to down-regulate therapy in summers, and we have to up-regulate the therapy in winters because of the vasoconstriction, diet, and other factors. Yes, the average blood pressure in our society is going up. So we have these Indian guidelines. As Vitull said, last 20 years we've been bringing out guidelines every 5 years. So it's time we'll be coming out this year with the latest guidelines. Our guidelines were in 2019. We recently came out with diabetes and hypertension coexistent situation, what should be the best practices in terms of management of these people. I'll just take you through in the next 9 or 10 minutes what are the current guidelines all across the world and how do our guidelines somewhat differ. Although essentially the guidelines will, guidelines are actually, as the word denotes, it's a guideline. They are not hard fast principles on which ultimately the treatment of any disease depends upon actually individualization of therapy. Every individual is different. We today are in a era when we talk of precision medicine. So every patient will be treated by physicians differently. But yes, as we talked of patient safety just now, some protocolization of therapy has to happen so that there is a uniform level of care that we are able to provide to our patients. This is how we define hypertension in our guidelines. Optimal, of course, is less than 120/80. We all know as the blood pressure goes up by 115 systolic and 70 diastolic, for every 20 millimeters increase in systolic or 10 millimeter increase in diastolic, the mortality doubles. But hypertension in our guidelines is defined as a blood pressure of beyond 140/90. And this is also the definition all across actually. The International Hypertension Guidelines, the European Society of Cardiology Guidelines, they all actually, we subclassify it into stages of stage 1, 2, 3, keep adding 20 to the systolic and 10 to the diastolic. We do recognize that systolic hypertension occurs more often in elderly, it is more difficult to treat, it is more resistant to the management, often requires multiple drugs, and also it creates and causes greater target organ damage, which you all know is in the eyes, kidneys, heart, peripheral vessels, and the brain. This was a bit startling, which happened about 4 years back. The ACC/AHA guidelines said that hypertension should be defined beyond as blood pressure of more than 130/80. By this criteria, almost 42% of the US population is hypertensive. Although this has not been adopted very widely, but it has raised actually an awareness amongst people that those who have a, so to say, what we in our Indian guidelines call as high normal blood pressure, they are equally at risks when they are harboring other risk factors. So as was just talked of, we treat an individual in totality. We do not treat just the high blood pressure. If you have an individual who has diabetes, other risk factors or target organ damage, you will obviously be more aggressive in managing these people. The Europeans have now given separately, and I just brought this because this is the latest guidelines. The ESC guidelines just came actually last month only, which I will share with you a little bit, because we know that the office blood pressure is not the only blood pressure which we today depend upon. We also ask our patients to record blood pressure at home. We don't depend that much on the ambulatory blood pressure because it is expensive, it is a little bit complicated, and it is a little intricate. Patients have to record their blood pressures at night. But we do know that hypertension is actually a gamut of multiple risk factors. Patients will often ask you, you know, there are genetic factors, polygenic factors. Monogenic hypertension is infrequent. Pollution is a very big factor for hypertension. Then renin-angiotensin system, endothelin system, and the sympathetic system, which we tend to target when we treat our patients with hypertension. We know socioeconomic factors like stress, lifestyle, healthcare access. These are all very important issues. The first and foremost issue is how you record the blood pressure. Unless you have an accurate measure, you will be either diagnosing falsely or you will be missing patients with hypertension. And these are some of the guidelines. We all know earlier we used to use sphygmomanometer, but India is actually a signatory to the Minamata Convention, by which mercury has to be taken out of all medical equipment, whether it is thermometers or blood pressure apparatuses. Even the Indian government has now given regulations, mercury sphygmomanometers should no longer be used. And so we all actually are now using the oscillometric automatic, we do not encourage the wrist blood pressure apparatus, but the upper arm blood pressure, which is the era for pulseless blood pressure apparatuses, will come subsequently, but as yet they are not actually approved for clinical use. This is some work we did when we realized that India will have to get away from mercury manometers. We did work with the IIT Roper, and we published this in the Journal of Medical Engineering. This is a digital sphygmomanometer, which is today being used actually all across the country, and these are actually the apparatuses which you all use. This was another concept which we thought, why not find a material for doctors which is similar to mercury, which has somewhat similar viscosity, and we could find Galinstin actually as a material which has half the viscosity of mercury. We did publish this work in scientific reports. We have filed a patent. Hopefully you might see this apparatus in the coming years. As I was saying, office blood pressure, if it is more than 140/90, you will diagnose hypertension, but the levels are less. Patients often come to us and tell us that the blood pressure at home is less. Well, that is what is expected. And in ambulatory, you can see the bottom line, blood pressure of more than 120/70. So the criteria you will be using for diagnosing hypertension for a reading that patient has brought from home as compared to the one that you are recording in your office has to be different. There was a time when we used to say we don't have Indian data, we are borrowing data from the Western society. That period has gone, because some of these large studies like the India Heart study has been published, which in the last couple of years, this is a study with 20,000 patients of hypertension across the country. And what we have found is that incidence of white coat hypertension is 15% and incidence of masked hypertension is 20%. Masked hypertension is in the office, you are not recording high blood pressures, but patient is recording high blood pressures at home. So these people are more unfortunate, they get missed and they remain untreated and they have target organ damage. So unless we have an awareness, and this will happen only if we will record home blood pressures along with office. So a practice, just as we have to take a cue from the diabetologist, there was a talk on diabetes some time back, that they depend a lot on the home blood sugar recordings. We have to start depending a lot more on the home blood pressure. And this is some work which we published in Indian Heart Journal. Only 1/3 of our patients today have home blood pressure apparatuses for the reasons actually socioeconomic and other factors. So this number has to go up, and more often we have to use home blood pressures. The third concept that I wanted to share with you is this risk analysis. Do not look at just the blood pressure reading. Look at the individual's risk factor, whether he has other risk factors, whether the person has hypertension mediated organ damage, and whether the person has clinical cardiovascular disease. So in that order, actually the risk so for a given individual with a blood pressure of 130 to 140, you can see person can be very risky if someone has clinical cardiovascular, stroke, MI, or renal failure. So the risk is dependent on presence of risk factors. It is dependent on, of course, the reading that you get in your office, but also dependent on the target organ effects that you see, which I'll show you next slide, and the clinical cardiovascular disease. So this is what actually we felt. We don't have an Indian scoring system like the Westerners have, a score method by which they can calculate what is the 10-year risk of an individual. But in a very simplistic manner, we suggested older the age, male sex, higher lipids, smoking individual with diabetes. This is an individual whom you will treat more aggressively as compared to someone who does not have these problems. And today we have these risk modifiers. Patient with autoimmune diseases, socioeconomic deprivation, mental illness. So we are also, besides these, looking at patient into a high risk subset. Those who harbor these risk modifiers, you will be more aggressive in them, because in them the effects of hypertension will be more. Well, hypertension mediated organ damage, as I said, you can see eye fundus, we do it, left ventricular hypertrophy, echo can be done in some of them, albumin creatinine ratio we should do in all people with long standing hypertension, carotid intimal medial thickness, endothelial dysfunction. So all these subtle features of effect attention on organs, if you can pick up before actually clinically evident CVA happens, or patient has an MI, or patient has heart failure, by the time actually the battle is already lost. But these are the people at the highest risk, and these people you will treat at a lower blood pressure also, as we showed, discussed. Well, Indians consume one of the largest amount of salt. Study which showed that consume 9 to 11 grams of salt, whereas the recommendation by the Indian guidelines is 3 to 4 grams. So you can see we are almost 2.5 times this permissible, and we know pickles, papad, chutney, anything that is preserved contains baking powder, which is nothing but sodium only. So one has to counsel patients, and this whole lot of list is available in the Indian guidelines, because we recognize we are high salt consumers. This is the fourth concept I thought I'll share with you, which most of you actually are aware of. The American guidelines have suggested these thiazides, calcium channel blockers, ACE inhibitors and receptor blockers as the first line agents. And why this slide I am showing? Because beta blockers are not there. The senior physicians are all used to treating hypertension with beta blockers, but actually the scenario has changed in the last couple of years, because we have realized that beta blockers have multiple metabolic side effects. They alter the lipids, new onset diabetes increases if your patient has been on beta blockers and diuretic. So a combination of beta blocker and diuretic is rather detrimental, because Indians have a predilection for diabetes, and this diabetes, the pre-diabetes that you have. So beta blockers have virtually gone out of vogue as first lines, although in special indications, like someone has coronary artery disease, heart failure, migraine, someone has an additional indication for beta blockers, young people with high intrinsic sympathetic activity, those kind of patients who come to you with lot of tachycardia, anxious in their 30s, obviously you will treat them with hypertension. With the beta blockers. This is the simplistic algorithm we have given. For younger people, you will choose A, that is ACE inhibitor or receptor blocker. For older people beyond 55, you will choose a calcium channel blocker, because they have a low renin hypertension. Hypertension in elderly is volume dependent, whereas hypertension in young is actually renin dependent. So you will hit at the renin angiotensin system, use either ACE inhibitor or a receptor blocker. We never combine inhibitors with a receptor blocker. But as a second step, you will pick one agent from one side and the second agent from the other. And there was an accomplished trial which showed us that A plus C, that is ACE inhibitor or ARB with a calcium channel blocker, is better than A plus D. Although earlier we used to believe diuretics with ACE inhibitors are the best. As a third step, we combine three. Now, a very important conceptual difference between epilepsy and hypertension, which I teach my undergraduate students often, is in epilepsy you use maximal doses of a single agent, but in hypertension you tend to use multiple agents which have effects at different systems, so that your side effects are less, since this treatment has to be lifelong, and they have a synergistic effect with this. So that is the reason that combination therapy, some of these latest guidelines, the International Society of Hypertension guidelines, say that as a first step, you combine telmisartan with amlodipine, which is possibly the most popular combination that is used world over. So as a step 4, you go on to add a MRA, and of course as a last step you will use other agents. The target that you want to reach, the Americans have said 130 by 80. If you want to remember one value, the target should be less than 130 by 80. We have been little bit more age dependent. Aggression is required, because in elderly people, some of them are frail, some of them can have postural hypotension, so one should be little bit more aggressive, whereas in coronary artery disease patients, obviously you will be much more aggressive. I'll just come to the last part of my talk as to what is happening. We know all this, what I was talking till now is already known to you, but how effective is this knowledge being translated into practices in terms of treating our patients? Well, the WHO has taken and formed this Global Hearts Hypertension Control Program, which has about 1 crore individuals have been treated, and the percentage of patients in whom blood pressure is getting controlled world over, especially in third world countries, is much higher. This is a beautiful algorithm which the WHO has given for India and for US, and you see, as I said, they say start with amlodipine, add telmisartan, and then add chlorthalidone. Chlorthalidone is considered a little bit better than hydrochlorothiazide, although we recently had a trial last year only which showed are almost the same, although chlorthalidone has a little bit longer duration of action, and so it is little more effective. Also in the popular all hat study was chlorthalidone. So if you are a purist, you might like to use chlorthalidone, but essentially doesn't make a difference. That is the guideline they have given for. So these kind of an algorithm, rhythmic approach, so that you make it as simple to practice and as uniform to practice. This is a very prestigious project of the Indian government, the India Hypertension Control Initiative, and you can see this is all across the country happening now. Lakhs of patients have been included, and hypertension, it shows, has to be treated at the primary level, not in big hospitals, because at the primary health was getting more effectively controlled than it was getting controlled in bigger hospitals. This is actually one of the initiatives that we have taken in our institution. We are actually the only private sector, because you know in India 70% of the outpatient visits are in the private sector, 30% of the outpatient visits are in the government sector. So unless you see hypertension can best be treated in the private sector, you will not be able to hit a large part of the population. So we started this Hamara program, the Hypertension Awareness, Management and Risk Assessment. We have called it as Mission Swachh Kavach, and what we have seen that a large percentage of industrial workers, a large percentage of slum dwellers also have hypertension, which is lying actually untreated. I'll just share last 1 or 2 slides with you. This is actually when the American guidelines came. At that time, we wrote an editorial in Circulation in which we did highlight this, that hypertension screening and diagnosis programs on a massive scale have to be undertaken. And in that, I think students can play a role, medical specialists can play a role. Dr. Karamveer Goyal is associated very closely with the program that we have in our institution on hypertension. And almost 1.5 lakh people in Ludhiana, their blood pressures have been recorded. It is one of the largest actually study in the whole country, and we are trying to reach more and more people. This is an editorial we wrote in the European Heart Journal when the European guidelines came up, and from them actually we did emphasize that protocol-driven standardization, something that I just showed you, that will make a bigger difference in terms of how we are able to treat a larger number of people. And I'll end here by just emphasizing that these guidelines provide an opportunity to improve actually public health by way of early detection, continued treatment, and a contact with the patient. Whether you use electronic media, modern methods of communication, you use paramedics, what best applies to your system. Patients have to be told and taught and re-emphasized that it's a lifelong commitment to treatment, and unless hypertension is treated on a lifelong basis, we cannot reduce the risks that it produces to the target organs. Thank you very much.